smart woman. And what we did on her is destruction of the genesis, something that we never have seen it before. And described this case a long time ago. And today, with printing the CBCTs, the surgeon can really have a good idea about where to place these screws along the roots and bringing the pieces together, bringing the segmental osteotomy forward, and bringing the canine next to a lateral incisor, a femoral on the lateral incisor. So you will see what are the problems I have to deal with. You can see all the classification of the different stress palette, and she's the worst. She's bilateral cleft palette with involvement of the palatal space. This is what she looks like on the CBCT. You can see here, this is the canine. This is the lateral incisor, and you can see the involvement on palate. And this is where we started. She's wearing a partial denture, and she's willing to go through this ordeal that I will explain in a minute. And she started like that, she finished her. And you can see that the center incisor is the lateral incisor. The lateral is a canine. Here is an implant here. The other central incisor is the canine. The bicuspid is the first. The lateral is the first bicuspid. So you can see that even though they look like they belong to the tooth that they are corresponding, there is a lot of work that has been done before, and I'd like to share with you how we did it. So what the thing is, I'm not involved in all of this. First is the work of the maxillofacial surgeon. They refresh the bone in the mesial in order to pretend to have both blocks welded. And you can see the patient is moving 1 millimeter a day. And you can see we moved all the pieces to the front, and of course she has a huge class 3. So we have to open and overcome this problem. The surgeon placed the posterior implants. They are not at the same level. So you see that there are surgeons that don't have a clue about orthodontics. So the more you know about orthodontics, the better surgeon you will be. And you can see here that this tooth is resolving the palatal root of the second bicuspid. So we are losing this tooth. Here we have a pocket of 22 millimeters. And you can see here the bone loss, what we call the posterior area. So this is the hot potato I have to fix. You can see that I have a lot of scars, no keratin to cover. I have overgrowth, as I mentioned, the canine, is the first bicuspid, is the first implant, This is a lateral incisor, this is a canine, this is an implant that is 8 millimeter palatally, is touching the root, which is resorbing here. I'm using this tool. So as a dental technician, the first thing I wanted to do is I wanted to wax myself the case to have an idea where I want to place the occlusal plane, how much I will need to open the vertical dimension in order to overcome the transverse problem was having that side. And you can see that I will need to do some root plasting in order to have the same diameters between these. I did the provisional restoration myself. I opened the light, I did the wax up of the teeth, and I also wax up the pink where I would love to have my pink. And I was showing my orthodontist friend how much he will have to incline lingually in order to minimize the transverse problem we were having on that side. So the first thing I did is I did a wax up, cut the teeth, and reline, doing an aesthetic mock-up to see if the occlusal plane was on the right place, and then decide how much tissue I have to bring down. Then I loved it. It was something that was possible for me. So what I did is I cut the teeth, I placed some provisional abutments on the implants, and then I have an idea how much I have to plump horizontally and vertically my soft tissue. So this is the first surgery. You can see that the first surgery, the papillas were cut here. Around the implants, I didn't elevate the papillas. I didn't cut the papilla between the two centrals because I have no bone here. And I grasped full tuberosity in between the two central incisors. I took advantage at that time and reduced cervically with an open flap the roots already in the first surgery, trying to have the same root diameter, especially on the line angles between the different teeth from a canine to a first premolar to come up with some teeth that look the same. I do a lot of root plastic. Thank God those teeth have already root canals, so it was not such a big problem. You can see there is a full tuberosity in between the teeth and a full tuberosity around this implant, which is really far apart. This is what it looks like 3 months later. You can see a lot of work to do. I still have volume to overcome, extract this tooth. There is a humidity replacement. So in the second round of connective tissue, the beauty of all these cleft palate patients is that they have had so many surgeries when they were kids. When they were kids, is that the palate is thick as the carpet. So you can really graft on the palate as many times as you want. You can see on the second surgery everything is flapless, it's tunneled in order to maximize the soft tissue, coronally, intentionally, all my teeth were with a flat scallop in order to bring the soft tissue, to maximize the soft tissue interproximally and locally, and then to push it in the second part. You can see that my hand doesn't tremble, and I take as big of a piece as possible to really overcome all the tissue that is necessary and cut all the tissue vertically and horizontally. compress them, they are not deep enough. So that's why my effort was to create as much tissue vertically to the implant head. And then I went to the office and asked, showed to my technician Yoshi how much pressure I want on each implant in order to push the tissue. So this is the provisional that we will be placing just to be able to push the tissue and overcome with the nice result. Usually when we do a provisional restoration of these characteristics, I make sure have some verification jig beforehand, so I know that my provisional is going to fit, which is sometimes if you don't do this extract step, a big problem. The other thing that I ask my technician is that I don't want any contact between my provisional and the elastic, so it's an open contact. So in that way I can guarantee I have a perfect idea that this bridge is just fitting my implant and my crown. And here we came up with an ideal scallop. And then I will have to place my margin underneath the soft tissue in order to meet the scallop that we have decided on the line. You can see that my provisional is placed in, the patient of course has been anesthetized. And then you can see an open line. I'm checking with my floss that I don't have contact and the distal aspect of my crown. And the most important is to have an idea how deep my finishing line has to go underneath the soft tissue in order to support that emergence profile. This is not easy to create with these cords in order to overcome this result. So this is where we started. And now, after all the surgery that has been done, implant, canine on a lateral position, lateral on a central position, canine on a central position, first bicuspid on lateral position, and implant. So you can see that we were able at least with control line angles, control emergence profile, and most important, control papilla heights in a certain level that looks pretty much decent. So you can see here the different steps we have gone through. The first periodontal surgery, the second periodontal surgery, and then the final situation before we place the final cut. You can see here all the amount of pressure that we have created with the provisional to come up with something that has the same profile from canines, from implants into teeth, all around the arch. You can see the effort here that was performed in order to surgically and prosthetically come up with line angles that have pretty much the same size in order to create an emergence profile that looks similar from one side of the midline to the other. And it's not easy to do. It's a lot of effort surgically and prosthetically, looking at roots that are totally different and that belong from other areas. So every time I do orthodontics in all patients like this one, I always splint my teeth. For me, there is nothing more frustrating on adult patients than not splinting the teeth and then having movements of the teeth open contact points, intrusions or extrusions. So in adult patients, I always split the teeth in different ways, as you will be seeing also later on after the break. So you can see here, looking at the tissue, how the tissue is going to be maturing as we go along, how much we are pushing the tissues. So we are favoring the papilla growth in between these. And this is the final job, the work. There is a pocket here, but there is no bleeding. The bone is 23 millimeters from the tip of the papilla. This is where we started. This is 1 month after I cemented it, and this is 3 years done. You can see how the tissue is, the tissue on top of the connective, on top of the graft is keratinizing slowly. Of course, we have been blasting all the scars she had from the maxillofacial surgery. And you can see how the tissue is becoming little by little keratinized and having a nice look of it. So you can see here, there is no bleeding, there is bonding of the bone above the apex, but this is the situation where we started, where we are, and how much we were able to bond just with segmental osteotomy and doing the destruction of osteogenesis, the bonding of the both parts and the final result. It's true that when you treat this type of patient at the beginning, they don't mind. By the time that they are finished, they are confident about their teeth and they smile totally different. This is the reality of my case. You can see how we take pictures with light boxes. They are 45 degrees related to the patient's head. And this is the iPhone video showing the reality of what we did outside. So you don't need to be from my line. We can use another prototype. You don't need to calibrate your camera so that sometimes photos are not as nice, but you can see here the inline area where we don't have any horizontal. And can we take this out? Okay, so we have discussed yesterday immediate implant placement, how to preserve what there is today. We're going to recreate what we have lost. We are going to show you from simple to more complex different situations and things that you probably do that we don't do anymore. The most important for me when it comes to recreate what there was, either with bone or with soft tissue, for me, if I have enough buccolingual bone to place an implant, if I have 4 millimeters of buccolingual bone, I don't do bone grafting. I compensate the volume with connective tissue grafting. As we said yesterday, the most important on immediate implant placement is to control the buccal blade on the adjacent implant, on the delayed implants. The most important is to control the interproximal bone, because this bone is going to support the papilla height. So the way that I do surgery is totally different from the way that I have been taught. Every time I'm going to place an implant, a single implant or a delayed mode, and I have sufficient procolingual bone, I elevate my slab partial thickness. I try to avoid as much as possible to expose my bone, because I have already 30% of resorption on my exposed bone. So let me show you the slim concept, how it started. Let me discuss the critical thinking, the surgical approach, and the prosthetic management, the benefits, and the take-home message. The concept is rather easy, is misunderstood, is underestimated, and basically is grafting crestally where the prosthodontist needed the most, and it's just grafting with patients' own tissue only. So we have two types of, this is something that I sold to Nobel in 2014. This October is going to be 31st of October, 10 years since we launched the book, and at the same time we launched this concept. But I've been doing this since 2006, around 2006. So I'd like to share a few videos. Basically, the more you want to bring the tissue crestal, usually we use this healing abutment that only helps for the surgeon to increase the verticality of the tissue and the volume and strength the papillas. In this way, today I don't place so much soft tissue on the vocal aspect. I make a cross, and then you can go over your healing abutment, and everything has been elevated partial thickness flap. I don't do vertical releasing incisions, so that means I have to go at least 1.5 sideways in order to overcome the volume that I want to improve crestally. And what I do is I suture the connective tissue to the vocal and palatal flap. And what we want is to stabilize, like everything we do in surgery. It needs to be stable, not movable. You can see that this healing abutment is 7 millimeter high, so we are just plumping the tissue in one shot around 6 millimeters. Okay. So this healing abutment only helps the surgeon. It stays there only 3 months because what we want is I have some music on in the can you put it on? So it only helps the surgeon to maximize the tissue crestally. It's really simple. It allows excellent primary closure, and it's a biological approach that is just really friendly because you take patient's own tissue. So the morbidity and the inflammation is much less than using a membrane or any xenograft material. And predictability is just amazing. So when we are going to increase the soft tissue vertically and horizontally, 99 of the dentists that I know and surgeons, they do the wrong incision. The more you want to improve your soft tissue vertically and horizontally, the incision should be as buccal as possible. 90% place it here, so by the time that you want to close it, this flap goes up and back, it's impossible to close it. So every time you want to increase height, your incision is more buccally displaced. The more the wider the ridge, the more you will have a vector in order to improve the height of your soft tissue. You need to be aware that the more tissue you put on the palatal aspect, the more this incision that was buccal will go palatally and will be difficult for you to suturate. So you will need more displacement of your buccal flap to really close it. So that's why the thicker tissue is on the crest, less and less tissue is placed in the buccal, because usually if you put too much on the buccal, you will see that you have a difference on a dissimilarity on the volume you are creating on your implant with respect to the adjacent tooth. So the beauty of having this slim healing abutment is acts as a bond. So the tissue won't move, and it's easier for you to come outside of your flap, taking the connective tissue, getting out, and suture. So the soft tissue is stable on the crest, and then you suture it on top of it. We only maintain this abutment 3 months. Why is that? Because if you have placed the implant deeper, because maybe you have increased the bone can grow on top of it, and if you leave it for 6 months, it will be impossible for you to remove the implant. So this technique works only for 3 months. So basically, 3 months later, you take out your slim healing abutment and place a normal healing abutment, and then it's the prosthodontist who starts pushing the tissue out. And this is a healing abutment that is designed to be done one-stage surgery. So, how many cases see this one? What is important? Many dentists that come to our courses, they calculate the soft tissue that is too narrow. And what we want is that the tissue fits the mesiodistal aspect of the tooth you are replacing. So this way you are able to support the proximal papilla one shot. You can see that if you are too short and not touching the adjacent tooth, you won't support the papilla in the same way. The more you place your incision on the center, and the more tissue you put on the back, the more difficult it will be to suture it crestally. So then you can go from this healing abutment and have something, an intermediate healing abutment. You can go wider healing abutment. You can make a custom healing abutment. You can jump directly to a final zirconia abutment. At that time, 10 years ago, we didn't have the ambulation screws that we have today. So pretty much everything was cement retained rather than screw retained. Today, everything that I do is screw retained, especially because of the access to the implant head and the implant like this. So you know that I will explain how we create the emergence, how we modify this tissue as we go along. And here, when you have patients that have bleaching, it's difficult to evaluate the value. So this is a trick we use a lot. You place Vaseline on top of the teeth so we keep them moist. So this moisture stay longer and we have a better vision of the situation and decide if the value is correct. You can see the contact points are from there. This is the first page from Yoshi. As you can see here, really nice blending of the restoration. This is when we finished. You can see how much we are sticking out the restoration in order to confine the tissue and allow the tissue to be kind of sequestered in this place. This is the initial situation. You can see we usually place the bigger amount of tissue depending upon the height of the patella we are looking for. It's about a month later, this is 2015. We got an article of PPT about the swing concept. And you can see all the different steps, all the prosthetic phases that will go in a moment, and how to deal with it. This is 4 years down the road, and the teeth has moved. If you look at it, the teeth has extruded. The contact point is not there anymore. She has some footing action. What we did is we place a little wedge and did a new composite. This is 4 years down the road. You can see that even though the tooth is printed from central incisor to the canine, we still have some movement. This is the iPhone video several years down the road. So how this started? I was training as a periodontist at the University of Washington, and over there we were using already concave hidden abutments. And we were not using straight conventional abutments because what we wanted was to improve the thickness of the soft tissue and really be able to create an abundance of soft tissue and be able in this way to hide better the connection with our implants. So you can see that with this abutment, I always saw that the tissue was gliding. It was never staying level to where I placed it. So I thought that making some holes into the hidden abutment will favor the suturing in a better way. But actually, this is not easy, and I will show you why. But this guy was beating all of them. As soon as I took the platform off, the tissue even grew on top of it and was disappearing. And then I saw that the more I was resting on top of my hidden abutment, the less cracking of my provisional. And I decided to place a prosthetic head. And those are all prototypes that were done by a patient of mine who is an engineer. So, if you look at it, this is an agility of the lateral incisor, and I thought at the beginning that the wider the platform on the top, the more I would protect the soft tissue. But actually, is the wrong answer because it's pretty difficult to have a primary closure, to have too tight of a suturing technique on the crest, and usually you lose height even though we have the volume, and we come up with something that looks nice. So those are pictures from the book. We have two versions of this hidden abutment. One was with a hole. The problem with the hole is that the pitch of the threads of the hidden abutment doesn't correspond to the pitch of your implant. So this could end up on the mesial aspect, difficult to suture. You have to suture with a 6-0 suture is not for every dentist. I had another one that was just a notch. You could go through the notch and pinch your suture in an easier way, but none of those really show the difference. Sometimes when it was interproximally, it was difficult to suture it, but the results were consistent as far as how much tissue we were able to grasp crystalline. It's true that the flap over it was more demanding, but the results were consistent every time. You want to have a perfect adaptation of your flaps, so you could see no incision whatsoever. These are the results that are years after, where you can see that the papilla height is pretty much level with the rest of the papilla. But this guy was just amazing. We were having all of those were done by myself. And I will share with you after the break how we modifying them just with lathe and carbide burrs, how we were reducing, and this concept can be adapted to any implant treatment. You can see here that if the surgeon sees this, the first thing is going to see on this cleft type of recession. It will do bone grafting. For me, I have enough so-called plate of 4 millimeters to place a 3.5 millimeter implant. I will compensate the volume, which large tissue. Pretty simple. You can see that the hip attachment usually was buried, and then we're jumping into a quite narrow was hip impression coping, and at that time I have a tight base on this double-added implant that was constructed by the same patient, and this way I had better less problems with fracture of my abutments and sorry. This is when I used to have my Instagram that was hacked, and you can see here the picture of the same implant 11 years down the road. This is a removable partial denture of this patient who is 82 years old, and with the advent of zirconia foot contour, zirconia teeth, removables with zirconia teeth, which he loves, and we did some composite, hybrid crown instead of extruding and making his life more miserable. You see the crown with some composite and doing some guided clasp-less removal, and was a happy camper. So you can see that we put it on the lathe, and then we grind it. The way that we do it is as one goes forward, the other one goes backwards, and we can reduce this way any hidden abutment. So let me show you this case that I showed you yesterday. Of course, it's impossible to do immediate implant placement. There is no bone to anchor the implant. And maybe when you have this type of resorption, the worst is to lose the palatal bone. Why? Because the more you lose the palatal bone, or the less tissue you have on the palate, the more difficult it is to create volume of the palate. So I like to use the small wire technique, which is epithelialized, de-epithelialized, which is subtle suture do in your family for 30 days because it's really painful. So I don't do it that way, and the best provisional ever
Cái
is
khung hình tạm tốt nhất cho bệnh nhân
to use the same patient tools.
đó là mình sẽ cố gắng tận dụng những cái răng thật của bệnh nhân.
I only do either composite, I don't do any type of Maryland bridge
Tôi không có làm cầu cánh dán,
I do it in composite
tôi chỉ có
or
dùng cái răng thật của bệnh nhân rồi dán composite,
same use of the patient, I cut it and I bond it to the patient.
dán vào hai cái răng hai bên.
So it was a really stormy healing. What you should know is that every time you
Điều đó là khi
and you grab with
mà mình ghép
line connective
bằng một
tissue,
cái miếng mô liên kết của miếng mô
many
thì
of a great percentage of them will have a
hầu hết các
defect
trường
in
hợp
the center.
mình sẽ có một vết hỏng ở vị trí cái
Now,
điểm giữa như thế này.
usually I wait 8 months before I go ahead and do
Thông
my
thường
implant.
thì tôi sẽ đợi 8 tháng trước khi tôi đặt
And
implant.
usually I do take a line where is the
Tôi kiểm tra
vocabulary
những
of
cơ
the
vị trí
patient
diện của cái
21.
mao xương
And
hai cái
have
răng
an
mình
idea
cắt như thế nào để mà có một cái
what I'm
nối
seeing
về cái vị trí.
is a bone defect vertically or
Ở phía bên dưới
it
mình
can
đánh
be
giá coi là cái
easily
vết hỏng hay
compensated
là
with
cái vết
soft
hỏng
tissue.
xương hay
You
là
can
vết
see
hỏng
here
mô
that
mềm để mà lựa chọn cái pháp ghép phù hợp.
soft tissue
Thì
problem
ở đây mình có
rather
thể thấy nó chỉ
easy.
là
What I
mô
like
mềm
about
thôi, thì
grafting
đó là
is
cái mà
that the
tôi
quality
thích.
of the bone
Khi
is
mà
much
mình rửa
better.
răng và mình dùng ống nghiệm mình ghép xương
If I
thì
go
mình
graft
có thể mình cải thiện được cái chất lượng xương của nó và bảo tồn nó
thicker,
tốt hơn.
it's coming from another part of the mouth.
Vì còn lại mình chỉ cần
Is
làm cho mô mềm ở cái
will
khẩu này dày
withstand
hơn.
any pressure that I will create placing my tissue crystally.
Và với cái phần xương ghép chất lượng nó tốt
It's
như
a
thế
good
này
way
thì nó có thể giúp mình nâng đỡ cho cái miếng mô liên kết của tôi ở cái vị trí mao xương nó tốt. Với xương như vậy thì nó cũng đủ để mình có thể đặt được implant. Thì đây tôi nghĩ là cái cách tiếp cận phù hợp nhất khi mà phải thực hiện đặt implant trì hoãn. Sau mình ghép thì lành thương sau 1 tuần trông như thế này. Mình càng cần dùng cái bánh mật mà nó càng nhỏ thì mình càng tạo ra được nhiều khoảng không gian cho mô mềm. Và đây là sau 3 tháng. Cái thời điểm mà tôi lấy dòng hình thì như bạn hôm qua tôi nói với mọi người thì cái độ sâu của implant ở những cái vùng mình cần ghép tái sinh thì tôi sẽ đặt implant ít nhất là dưới cái mao xương 1 đến 2 mm, bởi vì cái mình sẽ rất là dễ thấy những cái tình huống bị tiêu xương viền sớm, và cái sự tiêu xương viền đó nó luôn làm ở cái vùng cổ
So you can see
bất kể
here
là
we
mình có
have
làm gì.
volume, and now it's a matter of trying to push it, and you have different ways of doing it. You can anesthetize, as I told you before, I leave my skin abutment only 3 months.
Thì cái slim
This
abutment
skin
thì chỉ dùng
abutment
3 tháng
only
thôi,
helps the surgeon.
nó hỗ trợ cho cái việc mình thực hiện phẫu thuật chứ nó không có giúp gì cho phẫu thuật.
So in order to remove
Thì
this
để mà tháo được
skin
cái
abutment,
slim
you
cái
have
link
to pull
abutment
it,
này thì mình phải
like
kéo nó
champagne
ra,
for everybody.
giống như là mở cái nắp
Stains
champagne
that
vậy.
doesn't come out, you see it in the video.
Cái champagne nhiều khi nó
And then you
bị
can jump
nén chặt quá,
from
nó không có
this
đi ra
slim
được dễ thì nó
healing
sẽ bóp ra, nó
abutment,
đúng là như
surgical
là
healing
cái nắp
abutment to a
champagne.
prosthetic one. You can use
Kéo nó ra thôi. Rồi sau đó
customized, wider,
thay vào một cái healing abutment thông thường hay là làm customized healing abutment tùy mọi người, tùy theo
and
cái
then
mong
you
muốn
use
của
the
bác sĩ của
impression
mình.
copy that has the same diameter than your healing abutment.
Rồi sau đó mình phải dẫn hình bằng cái impression technique với cái đường kính tương đương với healing abutment. Rồi sau đó mình sẽ dùng những cái base và một hình sau cùng có thể là dùng thêm những cái
What I like to do
lỗ bọc
is
cắt tầm góc.
dental technician too, so I'm quite lazy. I want results fast, so I go from here to here.
Thì nhà tôi cũng nhiều khi tôi cũng hơi làm biếng cho nên là tôi bỏ cố
there
gắng tôi
is
lấy
to
dầu sữa bột
little by
luôn.
little.
Thì mình cũng thấy là cái mô mềm nó
You need to
cũng từ
understand that
từ
if you
dần dần
graft with
thích nghi
tuberosity connective tissue
với lại
graft,
cái
there is
vùng
not
mình sắp làm
such a
mô hình ở đây.
thing
Thì
as
khi mà mình ghép cái miếng mô liên kết vào
necrosis of
cùng
the
thì
soft tissue.
mà mình ghép được tốt thì micro filler mình thấy nó bị hoại tử.
This is the first time
Thì thực ra đây
that the
là
patient will be hurt.
cái
So
lần
usually
duy
we
nhất mà
use
bệnh nhân sẽ cảm thấy đau trong
corticosteroids and
cái
painkillers
bước mà
because
mình
it's
làm
the first time that
phục hình.
it's painful for the patient. You need to understand how the soft tissue behaves.
Mọi người có thể hình
The
dung cái
wider
cách
the
mà
healing abutment,
khi mình
the
gắn cái
more
healing abutment
the
mà nó
tissue
càng lớn
will
thì
recede
cái
toward
mô
the
mềm
apex
nó sẽ
and
càng bị
toward the
đẩy
center.
về phía chóp
So you will
và
see your
về phía trung
finishing
tâm.
line
Cho
sticking
nên
out
là nếu
of
như
the
mà
soft
cái
tissue.
đường hoàn tất của mình bây giờ nó đang
Lower
nằm ở phía ngoài thì
is
đừng có lo
to
lắng.
show you how we fabricate these abutments
Tôi sẽ chỉ cho mọi người cách
in the
làm sao
lab.
để mình có thể thiết kế
And you
được
will
cái
see
abutment
between
bên này ở trong lab.
a month, in
Và
3 months,
sau
the
vài
tissue
tháng mình sẽ
will
thấy là mô
follow
mềm
the
nó
anatomy
đi theo
of what we
cái
have
thiết
provided.
kế mà mình đã
The idea
thực
here
hiện.
is that the technician has to create a root, copying the root of the
Quan trọng
patient.
là cái thẩm mỹ người ta phải thiết kế cái abutment đó
We
với
don't
kích thước
have any
tương tự như là
subjective
cái chân
idea
răng
about
và cái
what
răng
it
kế
should
bên.
look like, but
Thì
objective way of fabricating an abutment. So you
tại vì
can
mình
be
thiết kế
judging
abutment như vậy
steps
cho nên cũng khá là
depending
chủ quan,
on
nhưng mà đó là cách
how much
gần
you
gần
are
khách quan nhất
acquainted
mà mình có thể
with
thực
the
hiện.
lab procedure and the prosthetics. You can see that the
Mọi người có
depth
thể
here,
thấy ở đây cái độ sâu của
implant
implant
is way too
nó
pressed out and not deep enough.
không có độ sâu.
And they have a cauterization because of that weak bone that
Bởi vì cái
I
khung
have.
xương mà tôi ghép ở cái thời điểm tôi
You
đặt
can
implant
see
thì
this
nó vẫn còn khá là yếu.
beautiful shot about what I was discussing.
Đây là cái
The tissue will
trên làm sao mọi
recede
người có thể hình
vertically
dung cái
and
lời mà nãy tôi nói, đó là
horizontally
khi mình
towards
đặt
the
cái
center.
abutment vào
And
thì
you
nó
will
sẽ
see
bị đè nén và sụp
how to
nhiều ở
align
cái
it
phía
how the tissue
ở
will
trung
push
tâm.
back
Thì đó là cái vị trí mà mình sẽ phải điều chỉnh sau vài tháng
and to have a perfect.
để mà đạt
Let's
được
go
cái
to the
kết quả như
surgery
vậy.
again.
Mình đem
So
lại
this is the
cái bước
tools.
mà mình đặt implant.
How far to come? Well, how to respect the papillas.
Để làm sao mà mình có thể bảo
I
tồn được
will
cái
never
gan tương ở đây.
go here.
Tôi không bao giờ
Then
được thực hiện cái
the
động tác
flap
gan
will be
ở vị trí này.
wider than the medial distal space. So always to respect the
Tôi
papillas
cố gắng bảo
and
tồn
everything
cái
is
gan
partial
tương
fixed.
thật là kỹ
What I
trước khi
want to
thực hiện cái
see
động tác
is
nó
the
lệch ra phía bên ngoài.
dense crustal soft tissue. I don't do vertical releasing
Tôi không có thực hiện cái
incision
động tác
only
dọc.
when I do GPR, and
Vì cái
usually
thực
I
hiện
do
tôi chỉ thực
only
hiện động tác dọc
one
khi mà tôi ghép xương
incision.
CPR thôi. Và thường thường ở
The
những trường
more
hợp
you
đó
do
thì tôi
releasing
thực hiện một động tác
incision,
dọc thôi.
the more you are decreasing the blood
Và
supply,
rạch
the
càng
more
nhiều
you
thì
are
càng giảm
creating scars.
cấp máu và
That's how
tăng
you do
nguy
it.
cơ tạo sẹo.
So this partial thickness flap,
Cái đây là một cái bản băng
my connective tissue gets supply, blood supply
mình
from
lập băng phần để một cái phần nền ở phía bên dưới nó có thể nuôi dưỡng cho cái miếng mô liên kết và mình sắp ghép vào. Đây tôi đặt
that
freehand.
time all cases.
Ở cái thời điểm đó
The
thì
mobility of the
mọi
flap,
người thấy cái bảng của mình
the
nó
7 mm in abutment.
được giảm
Not
căng.
all the system
Và ở đây
have
tôi đặt
such
cái
a
sling
high
abutment
in
vào.
abutment.
Thì không phải hệ thống implant nào nó cũng có cái healing abutment, có cái chiều cao nó tốt đâu. Nhưng mà ở đây thì tôi đang dùng Strongman, nó có cái abutment nó cao, cái healing abutment cao để mà tôi có thể điều chỉnh nó thành cái dạng sling.
Usually I
Đây là cái
place
miếng mô
way
liên
too
kết mà tôi
short.
lấy ở vùng nội cũ
I
thì
place
tôi sẽ đặt
way too much soft tissue on the bacal aspect. You will
đó
see
là tôi đặt cái đưa cái phần mô mềm
that
lên ra cái
this
phía
will
bên ngoài hơi
create
nhiều.
a problem
Và
later on.
sau này cái việc đó nó dẫn tới nhiều cái rắc
So
rối.
I always make density.
Như mọi người thấy ở đây
Beginning you try to
thì
fill with soft
mình
tissue
cố gắng
the buccal
lấp đầy các
defect,
cái mô
the
mềm đó
buccal
vào
bone
cái khuyết
defect.
hổng ở mặt ngoài.
You don't need that. If you only grab crystal, it's more than enough. By the time that you are pushing the
Đó là cái
tissue,
ca khi mà mình phải bổ trợ những cái khớp ở ngoài. Thì nhưng mà trong trường hợp mà không có khớp ở mặt ngoài thì bình thường nó chỉ cần ghép bằng năng xương là đủ rồi.
you will see a great result.
kéo dùng lực để
you
kéo ra
place
chứ nó không có rơi ra được tự nhiên đâu.
the narrower
Ở đây tôi
impression copy you
dùng
have,
những cái trụ impression copy nó có cái
take
đường
your
kính nhỏ
impression,
để mà lấy dấu vị trí implant.
and normally after the impression,
Và thường thì sau khi tôi lấy
you
dấu
should be
thì
using or placing the healing abutment,
tôi đặt lại cái
diameter
healing
of your
abutment
impression copy.
tương ứng với lại cái impression copy.
In this case, I was lazy.
Cái ca này thì tôi
I
hơi
placed
lười
the same.
cho nên là tôi gắn lại cái
You have to
sleeve
line
abutment,
my provisional.
cho nên là
Then the last what we're going to do
để tránh cái việc là tôi phải ném lại cái phần tạm.
how to bond back again the tooth
Giờ tôi phải dán lại cái phần tạm nó bằng răng hai bên.
or in something while we are doing the provisional restoration. So today you can
Thì
use
ngày nay mọi người có thể
screw them provisional
dùng cái
restoration.
phần tạm bắt bích.
At that time we used to do a full contour waxer.
Ngày đó thì cái xưa thì tôi làm mặt sắp full contour để mà xác định cái biên dạng cũng như là cái biên dạng xuyên nướu và cái biên dạng của mình bên trên.
The divergent cratering from the internal head all the way up to this ideal finishing
Sau
line.
khi mình làm mặt sắp ở phía trên
Or
rồi thì
anything
mình
you
xác
are
định là
removing
recoil
the
cái đường
verb, you
và
are
mình bắt
creating a pressure
mình bắt đầu
which
từ cái
is
đường tận đất mình sẽ thiết kế
and
cho
these
cái
are
vùng
usually painful
immersion
for the
profile
patient.
ở phía bên dưới tới cái vị trí của platform implant.
Exert a
Thì
lot
cái thời điểm mà mình đè cái ở bên
Of
phần
course,
sau sau
I'm
vùng
not
vào thì dĩ
going
nhiên là nó sẽ đè nén
to
cái vùng
create the
nhiều
same
sẽ
pressure.
khá là đau
And the pressure is dependent upon the type of connective tissue I have used. I have used connective tissue from
mức độ
the
đè
palate.
nén nó cũng sẽ
I
phụ thuộc vào cái chất
wouldn't
lượng
dare
ghép
to
vào đó.
place
Nếu
so
như
much
mình
pressure. Why?
ghép cái
Because
phần
I can create too much of a
cái
recession.
thì
That tissue is not strong enough.
đó thì nó sẽ
We
không
don't have
có
the same collagen type
nhiều
1
cái
that
thành
we
phần
can get
collagen loại
from
1 như
the
ghép luôn.
roti, so I will take it with more caution and we will zoom and I will discuss
Ghép
that
từ
after the
cái
break.
thì tôi sẽ cẩn thận hơn khi làm việc với cái ghép.
You can see here, now we're going to do our composite,
Mình đang làm sạch cái phần composite.
simple composite, bending inside the halo.
Trám lại với những cái composite một miếng một ngà và
We're
kiểu
going to polish.
halo cắt
Look at my book. 90% of the single tooth implants digestion tooth have composite.
khi mà tất cả chúng ta
Improve
tương lại thì hầu như là những cái nào bên chúng tôi đều sẽ có trám
contact
một
point.
miếng
This is the final zirconia abutment with the
như là
three
bất minh thì có nhà sau cùng gắn trên cái base.
We disinfected with 2,10%.
Tôi có từng mặc
In
xa
10
để
minutes, second time is coming really clean.
khi mình tháo cái silicone bên bên ngoài thì nó sẽ dễ dàng hơn.
This is
Sau
back.
khi khử khuẩn rồi thì tôi sẽ làm sạch lại bằng xe lại rồi gắn lại
With layer, plier.
với cái kẹp gấp thì
But
đưa
it
nó
looks
lên
like
vào đúng
you
vị trí
haven't
rồi
done too much.
tôi có thể thấy là
Basically, we
cái
have
thao
the
tác này
patient to
cũng
come
khá là
a
nhanh
month
gọn.
later.
Tôi sẽ có
And
một
within
lần
a
quay lại
month,
tái
you
khám sau
will
một tháng
see
thì
how the papilla are coming back. What is
đây là cái
important
phần tạng
is to
tôi đang
have
ném vào sau một tháng mọi người sẽ thấy cái
good
phần mô mềm nó thành
surface
hơn.
contact between teeth and the tooth. I need good interproximal contact
Muốn có cái tiếp xúc
to
niệm tốt
guarantee that this papilla will come
để
down
đảm
to
bảo
the
là cái gai nước
place
nó sẽ
allocated.
đi được xuống theo cái kỹ thuật ráp.
Cannot pretend to have
Sau
a
khi mà
perfect fit.
đạp xong thì tôi sẽ hoàn
Take
thiện
it
đến
out
phần lab.
and we add acrylic if necessary.
Thế là tôi sẽ
And
đạp lên một chút
there is no
như
secret.
ở cái đường
All
tắt.
this and polish and more polish.
Thì
And then you see the
cái
tissue
việc
is
cắt
coming
tóc
back.
thì rất là quan trọng của mình, chẳng phải là một cái
In abutment,
bí mật nào cả, lúc nào cũng phải đánh
go
bóng.
straight to the final abutment or screw retain conditioner. Matter can be applied when European technician makes
đây là
the
các
contour base
mà
and then they
những
try
cái thành
it.
viên châu Âu, người ta
So
được
my
thực
own lab at home,
tôi
we
có
bake it
lắp
every
da.
time we start removing things, the soft tissue loose, is shaped, it's normal.
Mỗi khi
And
mình
then
cắt
we myself as
cắt
a
ra thì
technician, I
cái
study in
dung nham
revision.
đường của bệnh nhân nó sẽ hơi thay đổi một chút.
You don't
Đây
have
là
too
tôi
much
đang
trauma, I want more
làm
pressure,
việc
the
với lại cái
contact
thực viên của
point
tôi
is
mà có được
concave,
cái màu
I
ở đây
want
nó
to
không có
push
nhiều
it
chroma
more
như
on the
vậy,
canal. I need more contact
hay là
points
tôi cần
interproximally,
thêm nhiều tiếp xúc
I
của
want
phía
more on
bên
the surface, I need to push more interproximally, and buccally,
khi một
what
bên
you
nó
make on the
nằm
second
rõ trên cái gai nước thì nó nhiều hơn.
bake,
Ở đây là cái lần cải cách thứ
tries
hai.
to make all the indications now. You
Là
are
làm
way
theo
too
cái làm bên theo ý tôi rồi đó, giờ mình sẽ đợi.
dentiness, too much chroma. I like the contact point. I will
Tôi
add
thích cái tiếp
some
xúc rồi,
composite on adjacent tooth.
tôi
Too
thích
much
cái khớp cắn rồi.
tissue. So I start
Thì giờ tôi sẽ bắt đầu
modifying everything he has
điều
done.
chỉnh.
I need more contact point on the distal with, and then on the glaze he tries
Rồi
to
khi mà
compensate
nướng bóng thì
everything,
cái thực viên sẽ
add
điều chỉnh lại
contact,
thêm một chút nữa
and
về
then
những vị trí tiếp xúc và cái màu mỡ
modifying the final crown to finish the case.
để mà kết thúc ca.
Once I have the final crown the way that I like it,
Khi mà tôi đã
I
có cái khung
modify
hình
the
mà tôi
contour
thích rồi
way
tôi
to
sẽ
concave.
thì tôi thấy là ở cái răng kế bên nó hơi
I want to push my
nó hơi
papilla.
lỏng, cho nên là
I
tôi
want to have
làm
the
thêm để
contact
mà
surface
đẩy
and
cái
cover point,
nướng là thêm một chút.
and I make one contact after the other.
Tôi sẽ thực hiện một cái làm xong một bên contact trước khi mà tiếp tục cái bên còn lại.
Create
Khá
a
là đơn giản thôi.
polish.
Tôi đánh bóng.
Once I have done one side,
Khi mà tôi đã xong một bên rồi thì tôi sẽ tiến hành với cái bên còn lại.
I open the space, and how much do I open? Pretty much level to the contralateral papilla. Okay.
Thì cái điểm thực chiến mà tôi dùng để mà biết được coi là cái điểm cái vị trí tiếp xúc nằm đâu thì tôi sẽ dùng với những cái răng thật còn lại.
Instead of closing the spaces, I'm opening the black spaces.
Thì thay vì ở cái giai đoạn này mình cố gắng đóng kín hết các thành nhân đen và bằng một bên thì tôi ngược lại tôi tạo khoảng để mà cái thành nhân đen này nó sẽ được đóng bởi mô mềm sau này. Tại vì cái vị trí này mình đã ghép ngày xưa mà tức là mình đã làm ra mình đã ghép cái viên monocat đó vào cái gai đầu đó. Đây là cái thời điểm mà tôi tháo cái bức hình tạo ra và tọt cái ở bên mình của mình cái bên mình của mình sau cùng vào. Thì cái việc mà tôi nhét vào cái lỗ bắt vít đó là một cái polymer có tích hợp bạc để mà tăng cái khả năng kháng khuẩn.
Of course, we desiccate the tooth and the colors look nice.
Thì hiện bây
And
giờ
come
thì
back
về
months
cái màu thì tôi vẫn chưa có hài lòng lắm. Bệnh nhân quay lại sau một tháng tái khám thì tôi hỏi các bệnh nhân thấy sao.
And this is how the tissue is coming back little by little.
Thì đây là cái hình ảnh thấy
Even
cái
though
mô mềm nó càng lúc càng
the
trưởng
tissue
thành.
is coming down, and matter of time.
Chỉ là vấn đề thời gian thôi, cho tới khi mà mô mềm đã lấp đầy
Be
hoàn
careful
toàn cái thành
every
đen.
time that you
Mình
place
phải
a
cẩn
single
thận
implant.
mỗi khi mà
As I
mình
told
đặt
you
implant đơn
yesterday,
lẻ
not
thì
check
hôm qua
the
tôi đã nói
rest
rồi, mình
of the
phải kiểm
contact
tra
point.
lại cái tiếp xúc của
And
những cái
usually
răng
we
bên cạnh.
close the contact
Thì
point if
khi
there
mà
is no contact because it's not the
ở những
distal
cái vị
one
trí
related.
mà cái tiếp xúc nó lỏng thì
When
mình
I'm
phải đóng
free,
những cái tiếp xúc đó chứ nếu không thì răng nó có thể dịch chuyển.
space,
Thì ở đây mình đã đóng những cái tiếp
this is
xúc đó
how
rất
I
kỹ rồi đó.
started, how I
Đây là
finished,
trước
no
điều trị
idea.
và sau cái điều trị chưa lý tưởng lắm.
The rest you can see that the volume of the papilla
Có thể
is
thấy cái
shorter
phần gai đường cái phần gai
than
đường
where
nó
we started.
thấp hơn
But
và
this
vị
is
trí
7
mới đầu
years
mà
after.
bạn đã bắt đầu
You
được
can
cái điều trị một
see
chút. Nhưng mà
I put too much soft tissue. You remember? I was
sau 7
telling
năm
you
thì
I put
thực ra
way
thì
too
mọi người
much
thấy là
tissue
cái
on the
phần
back.
ngoài như bạn nãy tôi nói là
So
những
you
cái
can
phần ngoài nhiều
see
quá
how
cho
the
nên
tissue
là
is coming down
ở
and
những cái vị trí là gai đường thì nó đã lấp đầy hoàn toàn rồi, nhưng mà ở phần ngoài hơi nhạt.
you can see the leveling of the papilla.
Bạn thấy cái vị trí của gai đường nó khá là khác.
So So let me jump a little bit forward.
Thì để tôi nói thêm một chút.
I have 10 minutes.
Còn khoảng 10 phút thôi.
Okay, so how much do I have? 5 minutes, okay. So I have 5 minutes. Let me show you
Mình còn 5 phút
the
tới cái
thing.
team break.
So since 2019, I
Năm
use
2019 thì tôi bắt đầu
the Thai Ultra
sử dụng cái implant Thai Ultra,
has an anodized collar.
có cái cổ
And we
anode
see great results.
và nó có cái kết quả rất là tốt.
Nobody can tell from the
Khi
implant.
mình nhìn cái hình này thì chúng sẽ không có thể nói được là cái răng nào là cái răng của cái implant.
Crystal
Và
connective
các bạn
tissue.
mình khi nhìn khám xét vừa rồi mình ghép cái mô nốt ở xương ống môn,
How we
mình
modify
xử
the
lý vàng,
toxicity based on the
mình
needed
điều
distance
khiển
space.
cái mô mềm ghép cái miếng mô
And
nó
then we
cao
jump to
ở
the
xương ống
normal
môn nó rất là gây
implant
nương.
and finalize
Rồi
it.
sau đó
So
mình xử
we
lý một
have
vòng rồi mình chuyển qua
many
cái ứng dụng mà mình thường hay giấu lên
cases,
xương ống.
and I would like to share the complex one,
Đây là một cái ca
especially when you
phức
have
tạp mà tôi
kids
chia sẻ.
that have an aneuploidy,
Đây là một
no
bạn
longer
nhỏ,
know today, I
cái
will
xưa
have
đã
to
được cắt chóp rồi.
immediately replacement as I showed you yesterday. But at that time,
Ở cái thời điểm
we
đó
were not doing that. And you can see we have
mình
a
đã,
fistula.
nhưng mà bây giờ thì bản thân mình có thể mình
She's
làm,
16 years
mình có
old,
thể đặt
in
implant ở
pain.
đây, nhưng mà ngày xưa thì
So
không có
we
làm,
did
tôi hướng dẫn làm cái việc đó.
socket preservation
Ở đây
technique.
mình nhổ răng rồi ghép vào thuốc xương
Usually
ống.
I don't use this technique.
Bây giờ
Really
tôi
painful.
không
Today
có
what I
làm
do is
thực
I
hiện cái
take
thuật lại
align
mua lên các kiểu như thế này nữa.
the
Khá
distal
là
and
đau
medial
bệnh nhân.
aspect, and I take only, and this is about perforation of 1 millimeter, and then I take all the lamina propria from front to back. This is really painful for the patient.
Với cái cách mà mình lấy cái xương này nó gây cho bệnh nhân
So
rất là đau.
you can
Cái
see
vị
how
trí
we do
vị trí
today.
của mình lấy sâu ở chính
I
giữa.
go over 1 millimeter each side.
Thì ngày xưa nếu
I
như làm cái kiểu này thì tôi
visualize the
sẽ đánh
distal
dấu
and
cái
the
vùng tròn ở
medial.
giữa và cái đường viền
The
hai bên,
palatal is
cái chiều
always
dài nó sẽ
shorter
cách
than
cái
the
vùng
dorsal,
tròn mình đánh dấu đó khoảng 1 mm.
and the incision is just 1 millimeter in
Và
depth
cái độ
in
sâu
the
của
center.
cái đường rạch
Is
nó cũng là 1
the
mm.
epithelialized tissue. As I showed you yesterday,
Hôm qua
I
tôi có nói
first
với các bạn là tôi sẽ
de-epithelialized with my
khâu
bird,
bạn mô ở
and
trong
then I
miệng trước,
cut
và
guaranteed
mình
that
sẽ
there
khâu
is no
trước khi mà mình rạch
epithelium left on my corners.
để đảm bảo
Then
là
I
nó không
suture,
còn cái
then I
biểu mô
place
và cái đường viền nữa.
my sponges, my collagen
Đây là
sponges,
cái
and then what I do
bước
is I
khâu
place my
đây là cái miếng
cyanide on
sponge của
top
tôi và
and
tôi dùng
remove
cyanuric acid để mà che phủ cái vùng
The
mô
idea
nhọn.
is this extension of 1 millimeter
Thì
go below
hai cái cạnh hai bên
the papilla
của cái vòng tròn này
to
nó
reduce
1
my
mm hai bên cái
better
vòng
way.
tròn thì nó sẽ đi vào cái nâng đỡ của cái đường.
Going back to the case I started, you can see all the fractures,
Tôi thấy cái đường nó có cái đường nứt ở đây.
how bad this it was, and we never elevate the flap. It's a flapless procedure.
Đây là cái
And I
flap
showed
mình
you
không lật
yesterday
vàng
to
gì
make
cả.
from vertical vista, small openings,
Thực hiện
just
một
to
cái
tag our
vàng vista
membrane
là mình đặt cái
and
tác động từ cái ngạch hành lang.
at the side. So this is where we started.
Trước
It
điều
is
trị
5 years down the
và
road.
đây là
We use the
sau
same tools as the provisional
theo dõi
restoration.
5 năm.
And what I want is just to pay attention.
Mọi người chú ý
We don't have enough soft tissues, so we
là
are
mình không có đủ mô mềm ở đây.
missing a lot of papilla. This is 2009 when she's 16 years old.
Bệnh
This
nhân
is
quay
the
lại điều
zero
trị tiếp
of
vào năm 2016 và bây giờ đã 23 tuổi rồi.
preservation.
Sau là cả lần thương sau
5
khi
years
mà
back down the road.
mình ghép bảo tồn xương ống sau 5 năm,
More resorption
chúng ta
to
thấy là
top,
nó có cái tiêu
and
sâu hơn
we
so với
still
cái thời điểm
have
ban đầu,
space
nhưng mà
for placing my
nó
implant.
không đủ để mình đặt implant được.
As soon as I see any vertical movement on my
Mỗi khi mà tôi thấy
cephalometric tracing, I wait another year.
trên
Always
trường hợp
waited
CFA
on
tôi thấy đôi
her
răng nó còn di chuyển
until
thì tôi sẽ delay
23 years
lại.
old to place
Cho nên đó là
her
lý do tại
implant.
sao tới cái thời điểm
And
mình
then
đặt
I do these extensions when I have short papillas. And we only grab the tristem. Okay? So we don't go above if there is a single myocyte, phenotype, like in this case, we just grab the crystally and on my Jason teeth in order to control the papilla portion. You can see when I place the progeria restoration, you can see the convexity compared to the concavity compared to this. This is a problem. It's not easy to show it, but the papilla rays will have a nice papilla coming back. Significant deeper, so we have a nice response to the study. This is the iPhone video. You can see being concave and have a different emergence profile of the tooth, the direction appearance. But as the tissue is maturing, you will see how the tissue is growing. This is when it's very provisional, how much I'm pushing. It's not enough volume to overcome the nice emergence profile of the tooth. But as we are going forward, I always do the 3 millimeter titanium abutment. This is 1 month, and this is 3 months later. You can see how the tissue is maturing, is growing, stabilized. You can see the long papillas, level papillas all around, and then you finish it. So you can see that you don't need to place as much tissue focal as to maintain. Having the crystal is just the most important part. It's been printed is 2009 against 2016. Look at my provisional model and enlargement of the final work 1 year down the road. You can see the height of the papilla perfect and on video several years down the road. Okay, so with that I will finish there so you can continue with your session. So thank you very much.